We are live, Doctor. You can start the session.
Thank you, Sai. Good evening, everyone. And friends, it's indeed a great honor and pleasure to welcome you all for this Ophthalmic Horizon Ophthalmology Postgraduate Update Program on this TNOA Thursday. And indeed, honored to be here with you and happy to welcome our moderator, Dr. Sharmila Devi, for this update program. She's the convener as well as moderator for this program. Thank you, Sharmila, for bringing the program together. I also want to express my thanks and welcome our esteemed chairpersons, examiners, and panelists. Professor Vasantha, her dedication to teaching is commendable. And we also have Dr. Murali Ariga and our panel of examiners, Dr. Vijay Shanmugam, Dr. Chandrasekhar, Professor M.R. Chitra, and Dr. S. Krishnadas. So thank you all for joining us and welcome to this program. And to our presenters, and I think we should congratulate them and appreciate them for willingness to step forward and present cases and topics today. So in the spirit of academic bravery and of course bringing them forward to be examined in front of all their friends. Even though this is a mock, I'm sure the examiners will show them what exams are all about and not really scare them, but bring the best out of these students. And we have one long case, one short case, and one refraction today, all very important aspects of this ophthalmology postgraduate exams. So today's webinar holds relevance because now is the exam season. So a lot of exams are coming up. So last webinar from TNOA was about FICO exams and FICO exams. And now we have the postgraduate update program about the case presentations. So I'm sure this will be a useful initiative from TNOA's part. So once again, I welcome all of you, the MC members and office bearers of TNOA, all the members of TNOA for this academic program. I'm sure non-academic, non-exam going PGs and junior and senior ophthalmologists will also be benefited by this interaction. So with this word, I welcome all of you for this program. I also want to give a quick update on what is happening on the TNOA front. On this weekend is very special because we have the TNOA mid-year meet scheduled at Aligri the weekend, Saturday and Sunday. About 200 of our friends will be joining for the multiple events, starting with the trek in Aligri and then non-medical as well as academic and non-academic program in the weekend, Saturday and Sundays. So I thank all of them for joining us, and those who are in and around Aligri, Vellore, welcome to join us for the Saturday and Sunday program. And so let's move on as we kick off this webinar. I encourage all participants to engage actively, ask questions. So not only the examiners, I think the participants are also allowed to ask questions, Sharmila?
No, sir.
So, okay, maybe
they can type in the chat box.
Yes, so that would be nice and interactive. So thank you once again to everyone present. I wish you all a very informative and enjoyable webinar experience. So over to you, Sharmila.
Good evening, everyone. On behalf of Tamil Nadu Ophthalmic Association, it's my pleasure to welcome you all to Ophthalmic Horizon, a postgraduate update program. It's the brainchild of President Nirmal sir, and he wanted a special program for postgraduates, which would be very beneficial for the postgraduates. And I'm sure this platform will be useful for you because we have a stellar panel of examiners who are not only examiners for MS, but also for FICO, FRC, Ophthalm. And they have a lot of expertise in clinical knowledge. And I'm sure this will be very useful for you. And this is not only going to be live streamed, but it will also be available for you on YouTube. So it will be serving as a good reference for you. Without further ado, we'll start the program. So first is long case. We have the mentors also here. So if at all the students need not get scared, if at all you have any doubt, you can all the mentors also will help you. So please go ahead with the first presentation, long case and glaucoma by Dr. Vedavalli. She's a final year postgraduate from the Temple of Ophthalmology, Regional Institute of Ophthalmology. Over to you, Veda.
Good evening, everyone present here. I am here to present a long case on primary open angle glaucoma. A 45-year-old male came with the complaints of defective vision in right eye for the past 5 months. History of presenting illness. Patient had defective vision in right eye for the past 5 months, which was gradual in onset, progressive in nature, and no history of pain, redness, or photophobia. And there is no history of glare, and there is no history of colored halos, and no history of frequent change of glasses, and no history of headache. Past history of left eye, phacoemulsification with foldable IOL with trabeculectomy with mitomycin C done 6 months back at Orivo GOH, and no history of diabetes mellitus, hypertension, bronchial asthma, coronary artery disease, and thyroid disorders, and no history of ocular trauma, no history of food or drug allergy. Treatment history: patient is on bimetoplast eye drops, HS, timolol eye drops BD, brimonidine eye drops BD in right eye for the past 6 months. Personal history: patient consumes mixed diet, no history of tobacco or alcohol consumption. Family history: no history of similar complaints in the family members. General examination: patient is conscious, oriented, moderately built, and moderately nourished. No pallor, icterus, cyanosis, clubbing, or regional lymphadenopathy. Pulse rate 88 beats per minute, regular rhythm, and normal in volume. Blood pressure 120/80 mm of mercury measured in right upper arm in sitting posture. Systemic examination: cardiovascular system, acicular blood sounds heard, no added sounds. Abdomen soft, no organomegaly. Central nervous system, no focal neurological deficit. Ophthalmic examination: head posture normal, there is no facial asymmetry. Eyes
Your voice is breaking.
Right eye, lids and adnexs are normal. Conjunctiva muddy, cornea clear. Anterior chamber, Van Herrick's grade 3. Iris color pattern normal. Pupil 3 mm. Pupil 3 mm sluggishly reacting cataract. Extraocular movements full and free. Fused blood present superior to limbus extending from 11 to 1 o'clock position. Cornea clear. Anterior chamber, Van Herrick's grade 3. Iris color pattern altered with patent peripheral iridotomy at 12 o'clock position. Pupil 3 mm sluggishly reacting to light. Lens posterior capsular intraocular lens with the posterior capsular opacification. Extraocular movements full and free. Best corrected visual acuity in right eye 360, not improving with glasses and pinhole. Intraocular pressure measurement done at 10:15 a.m. by Goldman applanation tonometry, 26 millimeters of mercury. Central corneal thickness with pachymetry measures of mercury. In left eye, best corrected visual acuity, not improving with glasses and pinhole. Intraocular measurement done at 10:15 a.m. by Goldman applanation tonometry, 12 millimeters of mercury. And central corneal thickness with pachymetry around 521 microns, and corrected intraocular pressure 12 millimeters of mercury. This gonioscopy done using Goldman 2-mirror gonio lens, showing in right eye superior, inferior, and nasal quadrant structures seen till scleral spur. In temporal quadrant, trabecular meshwork and scleral spur seen. In left eye, superiorly scleral spur and ciliary body band seen with patent ostium. Inferior and temporally scleral spur seen. Trabecular meshwork and scleral spur seen. This is a goniogram representation showing the above findings. Fundus examination of right eye done with slit lamp endoscopy with a 90 lens, meet a hazy lens changes, cup disc ratio, vertical cup disc ratio of 0.8, diffuse retinal thinning present, nasalization of vessels present, and bayoneting present. Vessels appear normal, macula foveal reflex dull, and tessellated fundus. Fundus examination of left eye, medium and thinning present, nasalization of vessels present, bayoneting present, and vessels appear normal, and macula foveal reflects the RNFL map showing loss of double hump pattern in both eyes, with right eye showing diffuse RNFL thinning present, and in left eye, superior nasal and inferior RNFL thinning present. Fields examination in right eye not possible due to poor vision, and left eye computerized automated static perimetry done using fast threshold strategy, whose reliability indices are fixation around 7%, and false positive and false negative are within normal limits, and raw data shows generalized depression noted, whose pictorial representation is seen in grayscale, and total deviation numerical plot, there is a generalized reduction in retinal sensitivity, and pattern deviation numerical plot shows depression in central and inferior arcuate area, and glaucoma hemifield test outside normal limits. High diagnosis: a case of right eye primary open angle glaucoma with grade 2 nuclear sclerosis with posterior subcapsular cataract with advanced cupping. Left eye primary open angle glaucoma post phacoemulsification with trabeculectomy with mitomycin C with functioning bleb with advanced cupping with the posterior capsular.
Veda, can you switch on your video?
Thank you.
Thank you, Veda. Thank you.
Thank you.
So what are you planning to do for the right eye?
As I already on maximal medical therapy, ma'am, 3 drugs. So I'm planning to go for right eye phacoemulsification with foldable IOL with trabeculectomy.
Would you go to the immunomodulator or you want to do plain trap? Would you want to proceed with the mitomycin C in this eye also, or you want to do only trap with the phacoemulsification?
Trabeculectomy with the immunomodulators, ma'am.
When do you decide about the use of
mitomycin
C?
To prevent bleb failure, ma'am. Previous failed filtering surgeries.
Would you call it an immunomodulator or a wound modulator?
Wound modulator, probably.
I think we're all used to the other thing. So
Okay.
they're basically anti-fibrotic agent.
Okay.
Yeah. Don't use the word immunomodulator. There's no.
Okay.
Yeah. Sorry.
Tell me. When will you decide about the use of mitomycin C?
Previous failed filtering surgeries, ma'am. We can use mitomycin C to prevent bleb failure, ma'am.
Okay, then.
In your institution, are you routinely using anti-fibrotic agent for all glaucoma surgeries? Have you observed glaucoma surgery being done without an anti-fibroblastic agent, without mitomycin?
Yes, sir.
So when you don't use mitomycin, when you say this patient, I'm not going to use mitomycin.
Open angle glaucoma, sir.
Is it the type of glaucoma or is it anything else? With this patient, you decide I'm not going to use mitomycin, and why? The mitomycin is basically something like a double-edged weapon. No? So you can have benefits, you can have risk as well. So you can have the risk of, so let us say, over-functioning bleb, a thin cystic bleb, overhanging blebs. And a lot of mitomycin is not all safe in every patient. In certain patients, you don't want to, like Madam was pointing out, if you want to enhance the success of the bleb and reduce the chance of fibrosis after the surgery, you want to use mitomycin in varying concentration depending on the risk of the patient developing fibrosis. In younger patients with thicker episclera and kind of a secondary glaucomas, you would use more mitomycin. In older patients, you'd probably use, for first surgery, you'd probably use less mitomycin, the duration of exposure. There's so many variables in the usage of mitomycin, and the strength of mitomycin also. And in certain patients, you would not like to use mitomycin. That's what I'm asking. Where would you say I don't want to use mitomycin, and what can happen? Suppose you have a young patient with myopic, high myope.
Can you use it with and high myope?
What will happen?
You expect the sclera to be thin.
Scleral thinning will be there. It causes the scleral necrosis may be there.
I think you have to look up and read up all the available references in regards to where you cannot use mitomycin and what are the plus and minus in the dosage and the duration of application. In young myopic males, particularly, we don't like to use because of the risk of hypotony, because the risk of complications in the long term. So we generally try to avoid mitomycin or go in for a very cautious, ultra low dose kind of mitomycin and so on. So you should know about the mitomycin.
Okay, sir.
I have a few questions regarding your history itself. You're talking about a gradual vision loss, and you seem to be sort of tailor-made to coming to a diagnosis of glaucoma from your history itself. Is that right?
No,
You're leading us to a diagnosis of glaucoma from the beginning. So the patient actually won't come and tell you had a glaucoma, unless, of course, you ask history of the left eye. You said a frequent change of glasses was not noticed, right?
Yes, sir. Yes,
So
sir.
why is frequent change of glasses important in glaucoma? Or
In case of
important in
increased
any patient for that matter? Even a cataract can cause frequent change of glasses, right?
Yes, sir. In case of glaucoma, there is increased intraocular pressure, sir. It causes ciliary spasm and accommodation failure, sir.
Yeah. So accommodation is the reason for which you are looking for changes in the glasses. You also mentioned something about thyroid disorders, right?
Yes, sir.
So what is the significance of thyroid in glaucoma? So why did you mention that the patient does not have thyroid disease? You asked for it. So what can happen, suppose a patient has a thyroid disorder, hypothyroid, hyperthyroid, or any kind of a thyroid, dysthyroid function. So what can happen?
Yes,
Why is it important as far as glaucoma is concerned? Just think aloud. So what can happen to the various aspects of the intraocular pressure when you have a dysthyroid function?
Increased intraocular pressure, sir. There will be.
Okay. All thyroid patients can have increased intraocular pressure, or what aspect of the measurement, what aspect of the patient is important in a glaucoma patient? You asked for thyroid specifically.
Differential IOP will be positive in case of thyroid ophthalmopathy, sir.
Okay, that's very good. And what about the episcleral venous pressure?
There will be increased episcleral venous pressure, sir.
You should also keep that in mind. That's why you should think each patient is individual, each eye is individual. Don't think generally every patient you have to think of the same thing. So thyroid becomes important. You also mentioned about the time of the day and the intraocular pressure. Right? You said you measured the pressure at 10 a.m. or something, no?
Yes,
So why is the time of the measurement important?
IOP fluctuates, sir. Diurnal variation is present, sir.
Exactly.
The early morning IOP is high, sir.
Okay. So what are the different types of diurnal fluctuation? How many types of diurnal fluctuation is possible?
Morning IOP will be high, sir, and during night IOP will be less because of the supine position.
In all, I give you 100 patients with glaucoma. In all the patients, IOP will behave the same way?
So there may be variations.
Obviously not. So nothing like in medicine, you can't have anything dogmatically saying everything will be same in all patients. So what are the different types of IOP diurnal variations? I believe it has been described that about several types of diurnal fluctuations. There are 4 types essentially. The common one is the one which you said there's an early morning spike and it tends to go down towards the evening. The second one is a double spike. You can have a spike in the morning and the evening. The third one is a spike in the evening. The fourth one is a flat curve right through the day. So these are different patterns of diurnal fluctuation, which is why the time of the day and intraocular pressure becomes important. So read up that as well. IOP fluctuation and different types of diurnal fluctuation. And I think you also mentioned about the corneal thickness and intraocular pressure, right?
Yes,
you said the corneal thickness is so much and you corrected something for the IOP.
Yes,
what is the correction factor? Which one did you use?
Goldman applanation tonometry, sir. Thinner cornea tends to underestimate IOP, sir, and the thicker cornea tends to overestimate, sir. So we have to use the correction factor of about 0.7, sir.
What is the correction factor which you use, and what is the exact formula which you use? Is there a correction factor at all?
At 0.7, how did you write?
Yeah, you're right. See, the corneal thickness is assumed to be an average for the Goldman, is assumed to be an average of about 520 for an ideal sphere and all that, which is why we say 520 is okay. And depends on the population also. Sometimes the Indian population is said to have thinner corneas than the Western or Caucasian population and so on. So you need to know the Indian so-called average. Even South India may be different from North India. So corneal thickness. Generally, it is said that there are no strict nomograms or no strict formulae available for calculating the corrected IOP for any given IOP or any given corneal thickness. You can have a rough estimate, like you very clearly mentioned. We have thick corneas, we have thin corneas, we have so-called average corneal thickness. So there is actually enough for us to estimate IOP, and we don't have an exact correction factor, but some machines, some institutions use the formula correction, which is not wrong, but there's no exact estimate of correction. There's no exact nomogram or formula for IOP correction thickness, but corneal thickness, yes, is very important as far as IOP estimation is concerned. Which is the glaucoma trial or study which told us the importance of the corneal thickness?
Ocular hypertension treatment studies, sir.
Perfect. So that's, you must know that landmark clinical trial which gave us very clearly the importance of corneal thickness and all that. And you also mentioned that you did gonioscopy using a 2-mirror, right?
Yes, sir.
So this patient luckily had an open angle.
Yes, sir.
So what are the other mirror gonio lenses which are more useful in other clinical situations?
We have direct and indirect gonio lenses, sir. Direct gonio lens include Swan Jacob and Koipi lens, sir. Indirect gonio lens include Goldman lens, Zeiss, Sussman and Posner lenses, sir.
What is the advantage of Zeiss over the other lenses?
They can be used for indentation gonioscopy.
Why you are able to do indentation with that lens?
Because of the posterior surface is small compared to that of corneal diameter, ma'am. So we can use for indentation gonioscopy.
Posterior surface. Is it the
Contact surface of the lens.
contact surface? What is the difference?
Diameter is smaller compared to that of
Diameter, you must
cornea.
mention the diameter. Dr. Murali, in FRCS, no, a glaucoma specialist should not ask questions in a glaucoma case. Because
I
you
think
know
Sharmila
not
must
know.
put me in a cornea forum, I think. So I'll be as ignorant as anybody else. So.
I agree, madam.
Yeah, that, no, this is no here you only must conduct because the student has to know more about
No,
glaucoma.
I'm asking
And
very
that's for a joke.
very basic stuff
That's for a
all
joke.
what she has
No, as a
mentioned.
joke, I'm telling.
I understand.
Okay.
So I'm only picking out what she has presented. I'm not talking anything out of
And
what
then you said the defective vision in the left eye or the right eye is not operated. No, it's only for the past 6 months. You mean to say the patient with 3/60 vision said his defective vision is only for the past 6 months?
Yes.
How can it be, doctor? With 0.9 cupping? Huh? That's unlikely, no? So the history taking must be more correct. And when you're telling about that the general examination, CVS, RS and all that, you must say in this case, CVS, RS and general examination, you didn't find anything significant. Adalla ஒரே sentenceல முடிக்கணும். 9 no history, no history. It's very irritating for the examiner. I'm telling you. There'll be some 10 people coming at the same time sometimes with the same condition. It's very irritating. I'm telling you, you shouldn't irritate the examiner. Just like you got into trouble asking about thyroid, no? He remembered the thyroid only because you asked for trouble. Like that. That I wanted to tell. And then, why is the vision defective in the operated eye?
Posterior capsular opacity is there,
Yes.
and advanced cupping.
No. Even with advanced cupping, with the central vision, he can have 6/6 also, no? No, but
Yes,
what made you think that this defective vision is because of the PCO? Is there any other finding in what you have mentioned that also, which makes you think it's because of that? And Dr. Chitra is giving you see, always you remember there will be 2 examiners and the other examiner will try to give you a clue. You remember this. When they ask something else, no, that will be to make you remember. that to remind you, because you will be knowing the answer.
Yes.
Okay, if at all you want to do something for this patient, what is the first thing you will do? What, see, this patient has come to you, no? What is the first thing
Yes.
you will do? Because the other eye has been operated
The
fine.
left eye, would you do anything for the left eye?
See,
For
Sharmila is
the
giving you a clue.
For posterior capsular opacification, I will do yaw capsulotomy, ma'am.
Yes, see, so the patient will be happy that he will be having better vision at least in that time. No, are you going to get any good vision in the right eye?
After surgery, ma'am.
After surgery also, you shouldn't think so much for that.
I have a question regarding the YAG caps. Okay, keep thinking of the YAG capsulotomy which you just mentioned. So you have this patient has a field loss which looks pretty bad. Your VFA according to the field is 50%, which means half the field is actually technically gone. So you do a YAG capsulotomy. So what precautions you will take during YAG capsulotomy in such a glaucoma patient?
Yes.
You should keep that in mind. It's not like a routine PCO with just a routine cataract alone. But this patient
So what
has
complication you can get because of YAG? You think of that and then you can answer that question.
Post-operative IOP spikes may be there.
Yeah, you should be very aware of it. You can expect a spike. You should note the spike. So how do you check for the spike? You do YAG capsulotomy now with say what kind of an energy. I'm not going to the specifics of YAG caps. You've done a safe, very cautious YAG capsulotomy. And when you do check the IOP? Immediately after YAG capsulotomy.
1 hour after procedure, we can check.
And any precautions you will take to treat this spike?
We can give anti-glaucoma medications, sir.
Which one is the preferred one?
Which medicine?
Alpha agonist or beta blockers we can use.
The examiners must choose which one is best.
You should give a choice.
Before
Give us a
RPI,
choice.
which one will you give, actually?
Beta blockers we can give.
So you mentioned the field was taken after the surgery or before the surgery? The field which you showed on the screen.
After the surgery.
After the surgery. So this will include the PCO related change in the field also?
And that's what I wanted you to answer. I asked you, no? There is something in already what you have described. There is something which makes you think that the defective vision is due to.
Can you show the field, Vedant?
Yes, ma'am.
How many cases, Sharmila? I think we
3 cases now. 3 cases.
Three.
Only 3.
Long case, short case, and refraction.
Okay.
Can you just zoom it?
Yes.
It's okay. It's seen well.
Yeah,
Now
I think
you check.
it's seen well, yeah. So the significance is you have done this field with the PCO present. So ideally, you should do a YAG now, and this will not be a good field for you to compare subsequently. So you should actually repeat the field after the YAG is done. So then you will really know what is the underlying field. And in this, can you tell us how much of generalized depression is here in this field? Based on which parameter and the statistical indices? Which statistical index tells you the generalized depression here?
Mean deviation, sir.
Yeah, so how much is that?
Minus 14.7, sir.
0.7. So based on MD alone, can you tell me how do you grade severity of glaucoma?
Is based on mean deviation value less than -6, it is mild glaucoma, sir. -6 to -12, it is moderate glaucoma, sir. More than -12, it is advanced glaucoma, sir.
Perfect. So I think that there you escaped. So I think you're well read regarding that. So I think you should repeat the field after the YAG is done. And you also mentioned about the disc size and disc appearance. You just simply said 0.7 or 0.8 or something you mentioned about the disc.
Yes, sir.
So don't you think something else, the disc is important as far as description of the disc is concerned in any glaucoma patient? What are the parameters of the disc which are very important for you to describe as different parts of the optic disc, different parameters? Isn't the disc size important?
Yes, sir.
So any description of the disc should start with the disc size. Say, is the disc size average, normal, or something like it is approximately 2 point. How did you measure the? And you also mentioned just a cup disc ratio. You didn't specify, is it vertical or horizontal? You didn't mention it. See your slide. Just go back to your slide.
Yes, sir.
The disc description does not give me enough information about the disc.
Yes.
You see this. You simply say CD ratio 0.8, diffuse thinning, and all other features. It doesn't tell me anything about the disc size. Is it vertically oval? Is it horizontal? Is it round? Does it have the cup disc ratio? What you measured is vertical or not? So all those very simple things are very important. I think in neural rim you have mentioned, everything else you have mentioned.
Why size is important? Why is
Yes.
he asking about size? Is the optic disc of same size in same size in everybody?
Yes.
It's
lot-
of same size, huh?
Variations are there.
Hmm?
Variations will be there. Variations will be there, ma'am.
Yeah,
Right?
it
If I
is
ask that
expected.
question, it means
Yeah.
its variations will be there. So how will it vary? So in which patient it will be large? Where will it be small?
Myopic patients.
Hmm.
Myopic patients will have large disc, ma'am. Hypermetropes will have small disc, ma'am.
Hmm. Then you
Relate that
ask other
to the
questions.
disc size, no? That you have to remember.
Ma'am.
Okay, in case you are planning for surgery for this patient to the other eye, what advice you will give to the patient? What precaution you will tell to the patient before taking up the patient for surgery?
Chances of wipeout phenomenon, ma'am. After surgery.
How do you know about that? The chances of hypophenomena or more? What program will you do in the field?
Macular program, ma'am.
Macular program. I mean, macular program. What do you see?
Macular split, ma'am. We can see macular split.
Now, how much a field is seen with the macular program?
16 points we can assess, ma'am, using macular program.
No, extent of
Central 10 degrees.
how much is tested?
Extent.
Central 10 degrees. Ma'am.
In the macular program?
How does it differ from your 24-2 and this? Why it gives you more information?
Ma'am, I could not hear, ma'am.
How does it
Madam
differ?
wants to know the difference between the 24-2 and the 10-2 and the
Phase two
macular
and the
program.
macular program.
And what is the extent of field tested? And how are the testing points and how is the thresholding? How is it different in each of these tests?
This question will definitely be asked, doctor. Definitely be asked.
Yes. 24-2 done in cases of glaucoma suspects and mild glaucoma, ma'am.
No. The
it
distance
is-
in between the points.
The spacing between the points.
54 points are tested, ma'am, and
Between the test points, it's about 6 degrees in the 24-2. Correct? In the 10-2, what is the test pattern? Yeah. In the 10-2, what is the test pattern, testing difference, the point difference between points,
degrees,
test location?
2 degrees, sir.
2
2
degrees.
degrees.
And what about the macular program? Does it test 10 degrees? The macular program of the Humphrey is slightly different from other machines. So let's talk about the macular program of the Humphrey. So how many points are tested and what is the extent of the field tested in the macular program?
16 points are tested in macular program, sir.
Correct. And what is this unique feature of the macular program? Each of these points are tested how many times? Each of the points are tested twice. Only the central 5 degrees are actually tested in the macular program. So for Professor Chitra was asking, if you want to look at split fixation, the macular test is not the ideal test. You must do the 10-2 program. Yeah, the 10-2 is more useful in the macular program for picking up split fixation and so on. So the 10-2 is a 2 degree separation between test points, whereas the macular program has only central 5 degrees. And of the 16 points tested and thresholded, each of these points are tested twice.
Why will the patient lose vision when there is a macular split? Why? After cataract surgery, why will the patient lose vision?
What to say? Sudden loss of vision, with idiopathic.
Now, what is the risk of the macula split in the so-called loss of central vision in a patient like this? What is the actual risk? What is the percentage of risk? Is it 1%, 10%, 0.1%? Just take a guess between these three. 0.1, 1, 10. How high is the risk or how low is the risk?
1%.
1%, is it? Which means out of 100 people you operate, at least 1% loses central vision.
0.1%.
0.1 is more realistic or even less than that. The risk is actually very low. So for the fear of the loss of central vision, we don't stop operating. Have anybody in your institution stopped operating on advanced glaucoma patients? Because of that risk? No, you're not. Obviously not. Otherwise, you'll not having a glaucoma clinic. You'll not be operating advanced glaucomas. So you can operate. You give informed consent, inform the risk, and look up the recent literature which has been published from Shankar Nethralaya about the risk of wipeout after advanced glaucoma surgery. They have clearly mentioned that it's a very, very low risk. I think it's even less than 0.1%.
Yeah,
So
I used to tell that it's more in theory because I also haven't seen.
Actually, we
it's
have
very
not
low
seen
risk.
Like that product.
Yeah,
We have
but you
not
should
seen
know
patient losing
patient.
vision
Yeah,
after surgery.
yeah, patient should be informed, but we should take the precaution of understanding the risk is low and not offer the treatment. Do not hesitate to offer treatment to the patient. I have one last question regarding your other eye, the phacotrab, the bleb area operated. You described the bleb area, no? You didn't. Did you describe the bleb? How do you describe a bleb post-operatively?
What are the parameters you look for when you are defining a bleb?
They said partially avascular.
Yeah, what are all the parameters which you should look for in a bleb post-operatively? Initial post-op, late post-op. When any patient comes to you, what all should you look for in a bleb? There are so many classification methods for bleb classification also. You can choose any one and tell me about the bleb.
You can tell the Moorfields classification or whatever you read, right?
It's not there, no? It's not there.
She's not there.
Yeah, she was having some internet issues, I think.
Net issues. Even earlier it was there. She has come back. Yes, doctor.
Veda, they were asking you about bleb classifications. How do you classify blebs? How do you describe a bleb?
Unmute.
You're unmute பண்ணுங்க doctor.
Veda, unmute ma.
Yes, ma'am. Now audible, ma'am.
How
Yes.
do you describe a bleb according to the different classifications? You can follow any one classification. Yeah.
Moorfields classification and Indiana classification, ma'am. Moorfields classification, we see bleb height, extent of the bleb, and vascularity, ma'am.
In this patient, how do you describe? How was the bleb in this patient?
It is a avascular bleb with the extent from 11 to 1 o'clock.
Was it totally avascular or relatively avascular?
Relatively avascular, sir. With the diffusion area of around 20%, sir.
Percentage, okay. What about the bleb height?
It is around medium height, sir.
Okay, so you made an attempt to classify the bleb. You had a look at the bleb. So why should we know more about the bleb in this side? Why is this bleb important for this patient?
Functioning bleb, sir. We need a functioning bleb.
Correct.
For
All that
good
is
eye
correct.
control.
Looks like it's a functioning because you have pressure of 12, you said.
Yes, sir.
So why do I want to know more about this bleb in this side when you're doing something, planning something for this patient? So depending on the extent of the bleb, the success of the bleb, the amount of mitomycin and what kind of surgery was done in this eye, I'm going to extrapolate the same to the other eye. Suppose I had no bleb, I had extensive fibrosis, I had a huge bleb here. I will modify my treatment knowing the history of the left eye for the right eye, which is why I want to know more about the bleb in this eye. For some reason, yes, ma'am.
You said about ostium being open, but you didn't say anything about iridectomy.
She said, ma'am, she mentioned. She mentioned it as iridotomy. Yeah, peripheral iridectomy.
Oh.
Can a trabeculectomy be done without iridectomy? What is the importance of iridectomy?
Iridectomy should be done, sir, in trabeculectomy because the iris may go and occlude the sclerostomy ostium, sir. So iridectomy should be done, sir.
Okay, so what is the typical description of the iridectomy in a trabeculectomy? It is called
A
PBI,
broad-based,
we used to call it. Now, what is PBI?
broad-based peripheral iridectomy.
It's peripheral basal iridectomy. And like you said correctly, that to avoid the plugging of the iris into the stoma, and it should be adequate enough not to go and plug the ostium and so on. So, which is why even in an open angle glaucoma patient, we are doing an iridectomy not for the pupillary block component. We are doing it basically for these reasons and for other reasons too.
Okay.
Suppose this bleb fails. Suppose this patient has a bleb failure, becomes scarred and fibrosed. So how would you manage this patient?
Bleb revision surgeries we can do, sir, or bleb needling we can do, sir.
Okay. So during bleb needling, what are the drugs which are used other than mitomycin?
Usually we do-
Fluorouracil, sir.
Yes.
5FU. So how much of 5FU would you use?
50 milligram per ml, sir.
Yeah, in a patient, how much would you use?
This time.
Suppose if I'm giving, let us say, 0.1 ml of the solution you mentioned, so how much of my 5FU is getting into the eye?
You said 50 milligram per ml, right?
50 milligram per ml, you're giving 0.1 ml. So that becomes 5 mg. Yeah. So you sometimes give multiple injections. You can give subconjunctival injections. You can also do a needling and 5FU. And you should know about the other drugs and the dosage. You should know the dosage. You write a paper and as well as people ask. You should know what you're going to do for your patient. You should tell your staff nurse to tell you how much to give you. Suppose if I do phacoemulsification alone in the right eye, what will happen? I don't do glaucoma surgery. So what will happen? I do only a cataract.
It causes some amount of IOP reduction in angle closure glaucoma, sir. Primary angle closure glaucoma, sir.
In open angle glaucoma?
It
It
won't
won't
happen.
reduce
Doesn't
IOP?
Not much.
Why the pressure comes down after cataract surgery?
Lens may push and anterior chamber shallowing may be
Open
there.
angle patient.
In open angle also it comes down, doctor. So if you know why it comes down, then you will know that in both glaucomas it can come down.
Yes. How much time do we have? I think we're already in 45
I think we
minutes.
should move. Yeah, we should move to the next
Yeah,
case.
I think we're in 45 minutes for the first itself.
Veda will be very happy now.
Yeah, she'll be relieved. She's getting bombarded with everybody and everybody is just watching. You're not letting the other PGs answer anything.
We have two other examiners too. They'll be there for the short case and refraction. Vijay sir and DC sir also there.
I think all the basics have to be covered in any glaucoma. I think this kind of thing, I think she has presented very well. I think her presentation is excellent, but
Thank you, sir.
should go fine tune it and look at all the basics. Keep upskilling. Every time you have a patient, keep thinking as to why you are seeing what and why you are doing any particular aspect of whatever you do. There must be a reason for that. Don't simply, like Madam was saying, don't simply routinely say, patient, I saw the abdomen, I look for organomegaly, I look for nervous system and all that. All those things you must have, because actually I was not listening to all that. I knew you were going to say everything is normal, so actually I was not listening at all. But like you mentioned, you should keep anything significant you should mention and give the salient points and think of all lateral aspects. Now, whatever you say, there can be a lateral aspect to what question can come.
Okay, sir.
Thank you very much, Veda. Thanks to all the examiners.
Thank you, ma'am.
Vijay sir and DC sir, do you have any comments?
No problem. Just one comment. See, regarding the systemic, no. Whatever is relevant for the case, you concentrate. For a nerve palsy, neurology is important. Here, hypotension or hypertension. or any gross field, any cardiac problem, which will be more important for glaucoma. I'm sure Murli will agree to that. Otherwise, telling S1, all your lung sounds and all her and all is not that. That's what Vasna madam was telling. Correct, madam?
Yes.
Vijay, sir.
Okay, sir.
Hi, Sharmila. We'll move on.
Move on to the next case. Okay, sir. Next case, we have a short case on corneal ulcer. It will be presented by Dr. Tarani Priya from Tanjore Medical College. Over to you, Tarani.
Time, Sharmila. How much you're giving her?
Sir, it's 8:15, sir. Half an hour for her.
No. Examination, there are 24 candidates we have. So short case, everything is on time only now. Just give
Only
her-
examination and questions, everything put together, we have to finish within 30 minutes, sir.
30 for one candidate. Okay.
We have refraction also, which is always, like the most anticipated one for postgraduates. Tarani, are you there?
Yes, ma'am.
Yeah.
Myself, Dr. Tarani, Department
Try
of
making your phone horizontal landscape, then the full slide will come. You just try. If you hold it horizontal, the full slide will come.
Okay.
Now you can present. Yeah, thank you.
Myself, Dr. Tarani, final year postgraduate from Tanjore Medical College. Starting with my case. A 59-year-old male, farmer by occupation, came to our OPD with a history of accidental stick injury to the right eye 2 weeks back and presented with the complaints of defective vision, pain, watering, and redness in right eye since then. History of presenting illness. The patient was apparently normal before 2 weeks. Then the patient had accidental stick injury. For that, he took treatment on outpatient basis. Patient developed redness, pain, watering, defective vision in the right eye. History of decreased vision in the right eye, which was insidious in onset and progressive in nature. History of pain associated with foreign body sensation. History of photophobia, redness, watering, discharge, which is mucopurulent in nature present. No history of wearing of contact lenses, bathing in river or ponds, fever with rashes, skin lesion, loss of weight. Past illness, no history of any systemic illness like systemic illness, no history of any chronic intake of drugs, no history of any prolonged usage of topical medication, history of both a cataract surgery done at a private hospital 1 year back. Personal history, not alcoholic smoker, normal bowel and bladder habits, sleep pattern normal. So general examination, conscious oriented, moderately built, nourished and moderately nourished, no, not an anemic, no jaundice, pedal edema, clubbing, cyanosis, systemic examination within normal limits. Profile pic of the patient. Ophthalmic examination, head portion normal, skin over the face normal, no evidence of any skin lesion, uncorrected visual acuity, right eye hand movements, left eye 6-6, intraocular pressure, right eye digitally normal, left eye 12 mm Hg, duct both eye patent, Bell's phenomenon intact in both eyes. Right, profile pic of right eye and left eye. Slit lamp examination on diffuse illumination with low illumination and low power of magnification. Upper lid shows upper lid edema plus present, matting of flashes. No evidence of meibomitis, blepharitis, entropia, ectropia, trichiasis, and proptosis. Lid closure is adequate in right eye. Conjunctiva shows circumcorneal congestion. A central regular corneal ulcer of size 5 × 7 mm in the pupillary axis, which involves the epithelium and stroma with well-defined margin, ring-shaped infiltrate with mid-stromal infiltration beneath the ulcer. Peripheral cornea appear edematous. Above finding confirmed with fluorescent stain under cobalt blue filter. Left eye lids, normal conjunctiva and cornea are clear. Microscope.
slit lamp picture of right eye. Fluorescent stain under cobalt blue filter. Anterior chamber iris, pupil and lens could not be assessed in the right eye. Left eye anterior chamber is normal. Iris, pupil normal. Lens pseudophakic. Color-coded corneal diagram. Fundus of right eye could not be assessed due to poor view. Left eye was normal. Summary, a 59-year-old male, former by occupation, history of accidental stick injury, pain, redness, watering, defective vision in the right eye for the past 2 weeks, no history of any comorbidities. The ulcer was central, regular in the pupillary axis, which involves epithelium and stoma, well-defined margin, ring-shaped infiltrate with stomal infiltration. So diagnosis, a case of a right eye, moderate grade, progressive stage central corneal ulcer, probably due to fungal etiology.
Hello, Sammy.
Yes, sir.
கேக்குதா? அந்த photo
Yes.
போடு.
So the anterior segment picture and the fluorescent picture.
Sir.
Convenient anterior chamber not seen சொல்லிட்டியா? Inferior எல்லாம் கொஞ்சம் clear-ஆ தானே இருக்கு. Why you didn't mention hypopyon or something? Patient is having hypopyon or not?
No hypopyon, sir.
உனக்கு தெரியலன்னா இப்ப hypopyon இல்லைங்க. Okay. Describe this ulcer, na? What do you mean by regular ulcer?
So margins are well-defined.
Okay, well-defined margins. Fungal ulcer, how will you get well-defined margins?
Could be a mixed etiology, sir. It can be a bacterial or fungal cyst.
Okay, how do you find out?
Accidental stick injury and with ring infiltrate, from that evidence, it can be a fungal, sir.
So in fungal ulcer, what type of hypopyon you expect?
Immobile hypopyon, sir.
Size, color, how long, how much? Sterile, not sterile? And centerla, there's some clearing as per your photo. Centerla, there seems to be some clearing.
Yes, sir.
And male, superior also, there's a slight clearing. Anthartla, where is the stroma? There is any stroma there? It correlates with your fundus picture also, or fluorescent picture also. Is this going for perforation or not?
No, sir.
Then why is the centrally clear over there? It looks like a desmotocele over there.
Sir, it seems like in regression stage, sir.
Seems like regression. Regression you cannot say with the center, no? You have to see the periphery. You want to treat this patient or not treat this patient now?
Yes, sir. I want to treat this patient, sir.
Okay, how will you do it?
So I will was sent for I will take a corneal smear.
Tanya, can you switch on your video, please?
யார் நானா? எந்த ஆஃபா இருக்கா?
Sir.
சொல்லு சார்.
I will take a corneal smear and culture, sir. Send for
Can you stop share? Can you stop share?
Yes, sir.
So you're going to start treatment or not start treatment with your investigation?
I will go with my investigation, sir. For
So
systemic,
you want to Wait for investigation report before you start your treatment.
I will start the treatment, sir.
For that, you should know what kind of ulcer this is. You said probably mycotic ulcer. What led you to this thinking? It could be a
From the
mycotic.
clinical evidence, I would like
Just,
to go. Yes, sir.
Shamila, give me just 4 minutes, okay? History of injury of vegetation. Oh,
From
good.
the
Okay.
history itself,
It just gives you a clue. Okay. Looking at that photo, how was the lid? How was the conjunctiva? How was the cornea? Anterior chamber?
lid edema
Suppose it
plus
would,
conjunctival.
how would a bacterial lid edema be? How will a fungal lid edema be? What will the patient tell you?
So in case of bacteria, the patient would have associated blepharitis.
No.
What about the other
Why?
signs?
Discharge.
Regarding symptoms, how will the patient with the bacterial ulcer will behave? How will a patient with
Symptoms will be more than the signs. And in case of bacteria, symptoms will be more than the sign, ma'am. The patient will have a severe pain, discharge, watering, redness, photophobia compared to the sign.
What is the look of the ulcer? How does it look like? What are the features to say it's a fungal corneal ulcer? There are certain features, no, to say it's a fungal corneal ulcer.
Fungal ulcer will be a dry ulcer with feathery margins will be there, ma'am.
Only that?
Pseudodendrite will be present. Satellite lesions will be there. Rough texture will be there, ma'am. In some pigmented cases, pigmentation will be there. So in case of pigment fungal,
You can have some endothelial.
endothelial plaque will be there. Hypopion will be there. Fixed hypopion.
Okay, now you fixed your diagnosis as mycotic corneal ulcer. Provisionally, how are you going to treat?
Treatment of choice is antifungal is natamycin, sir. I will go with 5% natamycin.
First treatment of choice for a corneal ulcer.
Ma'am,
What is the first?
filamentary fungal is more common in.
What is the first drug of choice that you should give for a corneal ulcer? Cycloplegics, you should start with cycloplegics and then go on.
Oh, yes, ma'am.
What cycloplegic for this ulcer? Is it drops or ointment?
Atropine.
Atropine. Person, fungal corneal ulcer, Tharani is a bonus for you if you get as a short case. Tella, you should finish in 2 minutes. You should have read and long case. You have only 4 minutes. They will ask you 2 questions in history. They'll give you 2 questions in diagnosis. They'll give you 2 questions in examination and 4 questions in treatment and management. That's all. It will be same for all the candidates. So you have to take only 4 to 5 minutes before you finish. Go to the next patient. Rendu patient short case. All these are bonus questions. Why are you thinking? Everything is given in undergraduate books itself. Why are you thinking? Atropine ointment, 1%. You should keep on going. For how many days you give? Are you going to give ointment or are you going to give drops?
Ointment, sir.
What are the instructions you'll give the patient if you're going to put atropine ointment? Okay, second drug. Adukulla money adichiruvaanga. 4 minutes on, they'll press the bell. They'll just stop. What is the next? What you're going to do? You're going to give an atropine cycloplegic. I presume that you know why you're giving cycloplegic mydriatic.
Yes, sir.
Okay. Then what drug you want to give?
Then I will go for antifungal natamycin, sir. 5% 5% antifungal natamycin for every Harley, sir.
Okay. During waking hours, during sleep, you're going to ask the patient to wake up and then put the drops, or during waking hours only? If
So
it's going to be
during daytime every Harley, during night 2 hours once Harley.
for how many days? Are you going to send this patient as an outpatient, or are you going to admit this patient? What are the indications for your admission?
If the patient can't put the drops properly, if the compliance is not good, no.
How do you
If
know?
the ulcer is large,
You think that is an indication for admission?
if the ulcer is progressive, large,
If ingriye, நீ தானே பார்த்த?
yes, sir.
Yeah, then
Sir, in this case, the patient's ulcer progresses, sir, so I admit the patient.
30 seconds. So this is a progress ulcer, fungal ulcer. So you think this patient needs admission?
Yes, sir.
Okay. Suppose this ulcer is in the periphery, you will send the patient home, or the patient in the center, you're going to send the patient home. Suppose a very small ulcer, only 2 millimeter ulcer in the center of the cornea, you'll send the patient home?
Yes, sir.
Read AO, they'll give you the indications for admission. Okay.
Okay, sir.
Then, other drug.
Sir, if it is a large and
If, don't use the word if, you have seen the patient. You have seen the patient, you have described the patient. In the patient, what are you going to do? What is another thing? Central, there was some clearing with some elevation, right? If I presume you see the picture correctly. So, if it is going to perforate, then what will you do?
If the perforation is 3 to 5 mm, I will go for patch graft, sir. If the perforation is more than 5 mm, I will go for
No. Active fungal corneal ulcer. Active. Surgery ke vanda, medicine no mudikliye. Okay, any systemic drugs you want to give for this patient?
Oral ketoconazole, sir. Oral antifungal or ketoconazole.
You have any studies?
200 mg per kg, sir.
Central corneal ulcer, will it work?
Sir is asking you whether there are any studies for additional systemic antifungals.
MUD2 trial, mycotic ulcer treatment trial.
Okay, I think we are exceeding the time. Okay, finally, systemica. If it's going to impendingly going to perforate, what other will you give? Will say manual
Intrastromal oriconazole.
We have not gone there at all. அதுக்கு முன்னாடி you have to save this, I know. இல்லைன்னா ஷர்மிளா மேடம் ஏற்கனவே எப்படா பண்ணுவோம் சர்ஜரி பண்ணுவோம்னு வெயிட் பண்ணிட்டு இருக்காங்க. நீ விட்டீங்கன்னா நாளைக்கு காலைல போட்டுருவாங்க. அப்படின்னு என்ன?
What is the drug to prevent impending perforation? You want to reduce intraocular pressure?
Anti-glaucoma drugs.
சரி, அதையும் படிச்சுக்கோ. Anti-glaucoma drug. Suppose you don't treat or you treat this patient now. It's already 2 weeks now. And it's still not responding to the treatment. How would you classify this ulcer and what are you going to do? Sorry, Sharmila, just give me 1 more minute.
No, sir, no problem.
Sir, I will, if the ulcer is not healing, I will go for corneal debridement. Then I will go for corneal biopsy, sir. Confirm the diagnosis and.
No, அதெல்லாம் முதல்ல. We are classifying this as a non-healing corneal ulcer. What are the other things you'll go back and see?
will redo the investigation, sir. And compliance is not good or not. Drug
Okay,
compliance.
Okay, I'll pathiko. Treatment of non-healing and causes of non-healing. You have to go back, look at the lid and also. Okay, now surgical management. Suppose it is still not responding after 2 weeks, what else you can do? Or there is impending perforation.
For impending perforation, I will go for therapeutic keratoplasty.
Therapeutic keratoplasty.
Monotherapy, right? Monotherapy with natamycin. Would you like to add any other second drug, or would you? What is TS?
1%. I will add 1% voriconazole eye drops.
What are the indications for adding a dual drug? The second drug, so mostly it is septate filamentous fungi, so everything will respond to natamycin. But there are certain indications when we add a combination, right? We can add oriconazole, or we can do a targeted approach using intrastromal oriconazole or an intracameral wash. So what are the indications for it? One is an ulcer larger than 5 millimeters. If the density of infiltrate is more than midstromal, so or an impending perforation, you can add a dual drug, right? You can combine it with oriconazole, and in certain other cases you can even do a targeted approach using an intrastromal oriconazole, or if there is a hypopion, you can wash with intracameral antifungals. That is the TST protocol given by AIIMS, right?
Any injection in the cornea?
Intrastromal or intracameral?
What? They have done studies, even in Aravind, they have done studies.
Intrastromal or intracameral amphotericin B can be given, sir.
Amphotericin B now, அதுக்கு முன்னாடி நிறைய studies பண்ணது. Okay, now man, move on. Next, what are the other surgeries you want to do for this patient? Therapeutic, you said TKP, no? Will this work?
Collagen cross.
What is PAC-CXL? Does it work for fungal keratitis?
What, ma'am?
PAC-CXL, PACK. You said collagen cross-linking, right?
Yes, ma'am.
What is PAC-CXL?
It work more for bacteria than fungi, ma'am. Collagen cross-linking.
There are not many high-quality RCTs. So few RCTs say that it works for bacterial keratitis, not of much use for fungal keratitis. Polyactivated chromophore for infectious keratitis. Vasanta, ma'am? Vasanta, ma'am, are you there?
We have already finished, no? Actually, how do you know that this ulcer is still active? If you go to slide share, no, go for Dr. Vasanta's presentations. Some 25 exam cases have been discussed by me.
Okay.
So fungal corneal ulcer is the most seen in that. So you go see that. Okay. I think we don't have time to continue.
I have 5 more minutes, maybe we can actually. You can ask some questions when we have a few more minutes.
No, you have muted me, so I thought you don't want me to ask any questions.
I didn't mute you, ma'am. The host is muted.
You tell me how you will know that the ulcer is responding to treatment. That question will definitely be asked. How will you know? You have given drops. Okay, first of all, you must use a slit lamp to see whether there is thinning of the cornea in the clear area. Dr. Vijay Shanmugam was asking, no? So, because in the picture, it's 2-dimensional, so I don't know whether it was bulging forward to say that it is desmetocele. So, you must use the slit lamp with the slit image to see whether there is thinning or not. And you must definitely know whether the ulcer is healing.
Okay.
Otherwise, how will you change the treatment or anything? In most of the fungal corneal ulcers, there will be, see, there's a waste of time. Most of the corneal ulcer, there will be secondary infection also. So discharge will be there, edema will be there, chemosis also may be there. So you cannot tell categorically say it's only fungus, or it is not the fungus. There is only bacterial infection. So you must see whether the patient is feeling better, and if that surrounding congestion is come down. Usually in the temporal area, the congestion will come down, and with that you will know. Third one is the size of the ulcer will come down, and then most important thing is there is edema of the cornea around this ulcer. No, in the picture you
Stromal edema and infiltrate will come.
Stromal edema will come down. That shows the ulcer is healing. Based on that only you will continue the treatment. Okay. What is the latest investigation to see whether it is fungal, whether there is added bacterial infection, and whether the patient is healing with this with your treatment? What's the latest?
Confocal microscope.
Yes. With that you will know you will see the fungal elements, and then whether bacteria is also there. Did you attend that webinar? I saw that webinar. Next one, when you tell natamycin, you must definitely say that it is a suspension.
Okay, ma'am.
Why is it important?
We can assess whether the patient is using the drug
No,
properly.
yes, you must tell the patient that it should be shaken well before using, before putting the drops. So, and then the examiner will definitely expect you to say that it is a suspension.
Yes, ma'am.
Okay. I think we don't have time for further.
If you permit, can I ask only one question, Shamina?
Please go ahead.
I don't know whether I missed it. Did you mention anything about the nasolacrimal duct in your presentation?
Yes, it is patent.
Patent. How did you see?
That syringing, sir.
You did the syringing. Very good. Okay. Thank you so much. Thank you, madam.
Should you always syringe?
Ma'am?
No. Should you always syringe? You do Roplast test, and if there is a pus coming out, you need not even syringe. Automatically, you know, no?
Yes, ma'am.
If there is infection in the lacrimal sac, what type of ulcer you will get?
Streptococcal pneumonia.
Streptococcal. Sharmila has come now, no? So she will teach more about corneal ulcers. Okay, we'll go on to the next case.
Thank you, ma'am. Thank you, sir. Thank you, Tarni. So we move on to the next case on diffraction. Dr. Shanmugapriya from Villupuram Medical College will be presenting. Lata ma'am is also there as a mentor.
Good evening, everyone. I am Dr. Shanmugapriya from Villupuram Medical College to present a case on refraction. A 24-year-old male college student presented to our OPD with history of defective vision both the eyes for past 2 years. History of using spectacles for the past 2 years is present. His uncorrected visual acuity in the right eye is 6/60 and in left eye it is 6/36 with pin through to 6/9 in both the eyes. With his present glasses, his vision is 6/9 parts in both the eyes. Subjective refraction was done, and in right eye with minus 2.75 diopter sphere and with minus 0.5 diopter cylinder at 180 axis, vision is 6/6, and in left eye with minus 2.5 diopter sphere and minus 0.5 diopter cylinder at 180 axis, it is 6/6. Near vision both eye is N6, and the power of his present glasses is minus 2 diopter sphere in both the eyes. Retinoscopic refraction was done using streak retinoscope, done at 2/3 of a meter with the Tropicamide Plus as a drug. Retinoscopic power cross. The light got neutralized at minus 1 diopter sphere in horizontal meridian, whereas at minus 1.5 diopter sphere at vertical meridian in both the eyes. Working distance correction was done for 2/3 of the meter, which is about 1.5 diopter. And after working distance correction, in the power cross is minus 2.5 diopter sphere in horizontal meridian and minus 3 diopter sphere in vertical meridian in both the axes. So subjective value is minus 2.5 diopter sphere and minus 0.5 diopter cylinder at 180 axis. And with this, patient reached 6/6 vision. No drug correction was done. This is a prescription for my patient. Right eye, distant vision minus 2.5 diopter sphere and with minus 0.5 diopter cylinder at 180 axis, 6/6 for both the eyes, and near vision is N6 for both the eyes. I've asked the patient to use it for distant vision for constant use. This is Sturm's corner for the patient. My diagnosis is both eye compound myopic astigmatism with the rule. Thank you.
Over to the examiners.
Sorry. How do you use the pinhole? You said with pinhole it is 6/9, and with the glasses the patient is improving to 6/6. No.
Yes, ma'am.
How is that?
With glasses,
Tell me how you will use the pinhole. This patient has come to you with defective vision. Okay. Patient has come to you with defective vision.
Yes,
Immediately you will put the pinhole and see. Huh?
Yes, ma'am. If it is a refractive error, vision improvement will be seen, ma'am.
No, doctor. See, all PGs make this mistake. That's why I asked this question. Okay. He's already wearing glasses with -2. With that, he is improving to 6/9. Partial.
Yes, ma'am.
That's what you
Yes,
told.
ma'am.
See, you must use the pinhole after giving that correction. Okay. If he improves further than that, you know that only the refractive error is the cause for the defective vision. Even if he comes to you for the first time, the patient has got some 660 and 636, no?
Yes,
Immediately you put -2. 0.5 length povanga meduva, 0.5, 0.1, do 1.5. Unless you see the patient yourself, no, doing diffraction, you will never be used to checking the vision in your exam. So don't rely on the refractionist. At least 1 or 2 cases you'll see daily. Okay. Huh? You have a refractionist, no, in Vipuram?
Yes, ma'am.
Okay.
Yes, ma'am, we have.
Okay. So you must put an approximate correction, then see with the pinhole. But if you in 660, if you put a pinhole, myopes of course will improve, but very often you may not get the full correction. So you must put an approximate power, reach up to a certain level, then try the pinhole. Okay. Now Chandrasekhar will ask difficult questions. So
no, madam. You know, if you see the refractionists, no, they will write NIG, NIP. That means no improvement with glasses and no improvement with pinhole. Or maximum, supposing you say 560, no improvement with pinhole, what does it mean? Dr. Shanmugapriya? 560, no improvement with pinhole, if you say. What does it mean?
It could be other than refractive error, sir.
Okay. Supposing I said 360, no improvement with pinhole. I'm expecting an answer.
Patient has gone for ambulance.
You know, there is a limitation of pinhole?
Yes, sir.
What is the limitation?
3.5 to 4 diopter correction.
Not even that much, 2.5 to 3.5. So if you have -6 or +6, for example, you know, aphakic patient, you put +10 and then put pinhole. So that limitation you must know. You know, Dr. Lata madam is there. Vilupuram, you want to add anything or shall I ask? Basically, you know, retinoscopy is something which is very important for MS and DNB. The case will be kept as a dilated case there. Isn't it, Dr. Sharmila? You will have a dilated case only for refraction. So what all you will get is name of the patient or your age of the patient and what drug has been used. Only these 3 parameters normally will keep. Correct, no, madam? Vasna, madam? Dilated case will be kept for retinal. It's a separate case by itself.
Yes, doctor.
No other history, nothing. So what you have to do, normally what we teach is, you have done the first 2-3 parts correctly. So first is your power cross or your retinoscopy value. Second would be your distance correction.
Yes.
And third is what?
Subjective, sir.
You have done well. Third is subjective. What will be the 4th step?
Transposition in case of, again, like
after subjective,
I go for
Fantastic. So you need to transpose. If, to make it a minus cylinder,
Minus
equivalent
cylinder.
value. We are not going into types of transposition, but here you do to get a minus cylinder. Fantastic. Then what will be the fourth step?
Drug correction, sir.
You are very good. You need to do a drug correction. So here the question is, tropicamide is a cycloplegic or mydriatic?
Mydriatic, sir. So I didn't go for it.
Tropicamide is a cycloplegic. Tropicamide plus has got a mydriatic called phenylephrine. Okay. So some places they don't do, but it could be about 0.25 to 0.5, doesn't matter. That I will accept. So for the next step is your PMT, post-mydriatic or your drug correction. After drug correction, what will be the next step?
If it is a presbyope patient, we have to do near vision, add near vision.
Correct. Near vision correction, if any. If you write these steps, no, you will not miss. Then what is the next step?
Prescription, sir.
Fantastic. What is the eighth step?
Diagnosis.
Fantastic. So far, whatever you did is a straightforward case. It's a spherical and you have with the rule compound myopic. No issue at all. So the questions here would be, one thing you told, you want a minus cylinder. So what about the drug correction? Where all would you give a drug correction?
Drug correction is usually given for hypermetropes or hypermetropes with astigmatism, sir.
Okay. So you are going to talk about the drug. What are the drugs for which you will give? How much?
Atropine,
Correct.
1, sir.
Minus 1.
Minus 1.
Correct.
Homatropine, 0.5, sir.
Okay. Cyclone?
0.75, sir.
So they say 0.5 to 0.75. Tropicamide could be 0.5 or less.
0.5 or
Yeah,
less.
yeah, right, correct. What are the conditions where you will give? You are seeing a prescription. Plus 2.5, minus 0.5, 180 degree. So there are some people who will put it in the trial set itself and try to do, but there is a problem. But whatever you said is correct. So for what all you must give drug correction? You said hypermetrope, no?
Yes, sir.
So what all you will give drug correction? Can you put it in another way? Will you give for minus spheres?
No, sir.
Never.
Plus spheres?
Minus spheres you will never give. Will you give for cylinders? Any cylinder?
Plus cylinders, sir.
No, cylinder will come down like that. The cylindrical value, now I'll ask you only one question. What is the definition of astigmatism?
It's a state of refractive error in which refractive power is different in different meridians, sir.
The point focus cannot be formed. That point you have to tell.
Is it focal length or form?
Is it for distant vision or near vision?
Distant vision.
Both. It is not for near or distant. It is for both. That is why you bring the cylinder down. Only for plus spheres you will give drug correction. Where all you won't give exception. This is the question. If you know this, you will do your proper refraction. Which all conditions you should not give a drug correction for a plus sphere also.
Pseudophakics.
Fantastic. Fantastic.
Aphakias.
Yes, both done. I am 55 years old. Will you give or not? No accommodation, man.
Yes.
So aphakia, no accommodation. That's why you don't give. So presbyopic case, see around 40-45, there will be little bit. So that is now. And one more important thing is only condition, where a plus sphere will become a minus sphere. Which condition? When you transpose. The cylinder is more. That means in the same case, you will say you will give, you will say before transposition, you will say you will give. After transposition, you will say you will not give. Mixed astigmatism. But that is the only place, where you will not give because the sphere will change. Otherwise, all other places you have to give. Right? That is the importance of knowing drug correction. Okay, that is good.
Okay.
So here, whatever you said is with the rule, everything. So, how can you tell what is the difference? What is the mixed astigmatism? Plus sphere and a minus cylinder, all are mixed astigmatisms.
Cylindrical value is higher than the spherical value, sir.
Fantastic. If the cylindrical, if both are opposite, Sphere and cylinder should be opposite.
Opposite
If the
sides.
cylindrical value is more than spherical, it is a mixed astigmatism. Always. Very good. If the spherical power is more than cylinder,
It could be compound, sir.
it could be like it is. It is, yeah, whatever is the top. Yeah, fantastic. If both are equal, after transposition,
Simple astigmatism.
fantastic. So simple compound differences, the cylindrical value. Okay, right. Equal, same, or more.
Higher.
These are the things in retinoscopy they are going to ask you. So you have done a convenient distance of 67. Which why you would use that 2/3 of a meter?
It will be easy for access of the tri lenses to.
Because your arm's length. So easy to take. 1 meter is the ideal to calculate, but which is more, accurate? Longer distance or shorter distance?
Longer distance.
Yeah, longer, the smaller powers will be more accurate. For high myopic powers,
We can do radical retinoscopy.
radical retinoscopy within few feet away. If you're correct, not feet, inches away. Radical retinoscopy for, okay. Which lens did you use for your retinoscopy? Streak?
Streak, sir.
No. Did you use a plano or a concave?
Plano, sir.
Plano. Below or up? Did you use a Welch-Allyn? Welch-Allyn or Copeland?
Below.
Below is
Welch-Allyn model.
a plano. Correct. Where will you use the concave?
High power.
Which
lenses,
power?
sir.
You prepared very well. High myopic powers, you can use your. Okay. I'm really happy you're answering these retinoscopy. If you do this and answer all this, if they're giving mark only for a refraction, you will get 100 on 100. So as a retinoscopy, whatever you have done is good. All the other aspects is not important. So another important thing you must learn was about your pinhole, like madam said. So here mostly it will be only subjective. Okay. And you should also know about the diagnosis and the principles of management. That's what they will ask. Depending on the age, depending on the power, what will you do? And here one more thing would be, this you have luckily got a similar power. Another question would be, there is gross difference of power between both eyes. Inequality. What do you call that?
Anisometropy.
Yeah. So how will you classify that? Because you can't, okay, come to that. What will be the problem if there is a gross difference of power?
Binocular fusion.
Diplopia also will come, no?
Diplopia.
Because size 6 to 8% difference will be very difficult. Okay. So what are the types of anisometropia? Time up, Dr. Shamila?
Yes, sir.
Okay. Now, these are the things which we ask in refraction normally. What are the types of anisometropia? You prepared retinoscopy well, but this is also usually, depending on the power, they will ask you some questions. Till diagnosis, all your presentations were good. Not sure.
No.
So one eye normal, other eye is -4, -5. What will you call? Astigmatism, what do you call?
Myopic.
Simple myopic. Simple anisometropia, myopic or hyper. Both are minus, but difference is more. Then
Compound.
Compound. You got it? No. Similar to astigmatism. Simple.
Okay.
If one is plus and one is minus, same word.
Mixed.
It's also called antimetropia. Another thing is simple astigmatic or compound astigmatic. These are the 5 types of anisometropia. Only one thing is, you must remember that these things are very, very important for you to understand that difference in power can cause diplopia. Difference in power can be called diplopia. So these are the important questions in refraction. I'm not going into myopia. Okay? Anything else, madam?
Can I add something? Doctor, you must remember the definition for the different types of refractive errors. It will definitely be asked. Okay. And one more thing, when they have, theoretically, they will have diplopia with different powers and all that. But in my experience, I've seen most often people, if you don't tell them no, whether if you don't ask them whether there is any diplopia, they won't tell. This is not for exam. This is for your future practice, I'm telling. You put the glasses, put the trial lenses, ask them whether they have any problem. And in astigmatism also, when you're newly prescribing an astigmatic glasses, this is at 90 degrees, so they won't have any problem. On 180 or 90, no, they won't have any problem. If you're newly prescribing astigmatism, this is again for your practice, not for your exam. So you make them wear the lenses, see whether they are comfortable with that. Then only give the astigmatic lenses. Otherwise, you warn them ahead that they may have problems. Why they may have problems? When you newly prescribe astigmatic lenses, why they will have problems?
Blurring of vision in the axis. Other than that, sir.
No. They will have clear vision only if you give the correct astigmatic prescription. But they will experience a problem. It is given in AAO refraction book. You go, you go and read it, because when you search for something, you will gain some more knowledge. You will say, read something more. Because of that, I'm not telling. And in this patient, you will give glasses. Can you give anything else? Treat him with any other method?
Contact lens, ma'am.
Contact lens. What power will you choose if you want to give contact lenses?
It is less than 1 diopter cylinder, ma'am. So I'll go for spherical equivalent and give the contact lens, ma'am.
Less than 1 diopter, no?
It is only 0.5 diopter cylinder, ma'am. So I'll go for
0.5 you can ignore. Why you are able to ignore that 0.5?
Tear meniscus between the contact lens and the corneal surface, ma'am.
So
that will take care of the.
So when you give contact lenses, what exactly happens to the reflection?
Contact lens, tear meniscus, and cornea all together forms a single surface, ma'am.
Yes, the surface of the contact lens takes over the refractory part. No, so 0.5 we can ignore, but beyond that you may have to give glasses. So give correction for that also.
Okay.
That is the usual question that is asked. Okay. So next to that, any other way to correct?
Refractive surgeries, ma'am.
Yes. No, why you are having a doubt about that?
Okay.
Especially people who are owning refractive machines. If you go to that center for exam, okay, you are doing MS. No, I usually take classes for DNB, so I remember that. But you must know about refractive surgeries also. I think we have gone beyond time. Okay.
Only one point, ma'am. What are the features with which you will say there is a oblique astigmatism in retinoscopy? Here you've got a very straightforward case, 180, 90, small cylinder, no problem. But if it's an oblique,
conveniently chosen. I don't know whether you really saw the patient or you just written something.
Correct. Because it's a nice case, you presented well.
Really, she has seen the patient, ma'am.
Thank you. No. She's presented very well, prepared well. I'm very happy to see the answer. One of the best presentations I've seen outside of my institution.
Thank you, sir.
Yeah. Now, what are the features you say there is an oblique? 4 features. And another thing is question on how will you fine tune your cylindrical power, Jackson cross cylinder, or your astigmatic man, and how will you fine tune your oblique astigmatism? These are important questions when you have an oblique. You didn't see that.
For oblique astigmatism, we will check for skewing of the.
So that is one point.
That is
correct. That means when you move like this will move like this. Yes. You can see this will move like this.
Yes.
That is called skewing. Other 3 points. Okay.
The breadth,
width,
intensity of
not
light.
width.
Sorry,
correct. There is a. Have you seen my retinoscopy YouTube video?
Yeah, I attended your classes, sir.
I can guess. Okay, there is the width of the beam that will vary. Then there will be a break of the beam. Break of the beam, width of the beam, intensity and skewing. See, normally it will move like this or like this only. Here it will go like this. This is called skewing. Fantastic. And how will you say whether your cylindrical axis is correct or wrong? There is something like that in the straddling. You're fantastic. 45 degrees this side you do, 45 degrees that side you do, just like your JCC. Everything should be same. Then your axis is correct. Really, I'm very happy to see that you've given a wonderful answer for retinoscopy and refraction. Really nice. Thank you. Thanks to the professor of Villupuram Medical College And
Thank you,
anything
sir.
else? Yes, madam. Vasna madam, you can go ahead.
No,
Because
I thought we can finish it, sir.
finish,
Like
madam. It's a good
beyond 9
presentation.
o'clock.
Yes, madam. We have over 100 people on the YouTube, madam. I'm sure it will be useful. It would have been very useful for them. Thank you so much, Dr. Nirmal, Dr.
Okay.
Shamila, Dr. Vasna, madam.
Thank you,
A round
Sharmila
of
and Nirmal, for remembering me and calling me. Yes.
Thank you, ma'am. You're the teacher of all teachers. A round of applause to the 3 postgraduates from Chennai, Villupuram, and Tanjavur, who presented really well and were brave enough to face the very tough examiners. And it was a very good learning lesson for me as well. And I'm sure it'll be a useful one for all the postgraduates. Thank you very much, sir. Nirmal sir, you want to give the certificates? Thanks to all the examiners, Professor Vasanta ma'am, Professor Vijay Shanmugam sir, Professor Chitra ma'am, DC sir. Thanks a lot. All those points were very pertinent. Nirmal sir, you want to hand over the certificates?
Yes, sir. My slide visible? Yeah.
Yes, sir.
So first of all, let me congratulate the presenters. I'm sure it needs a lot of guts to come to an online forum and present. So even within a college, it's a select crowd and our own friends. But in an online forum, which is recorded for posterity, being a resource and facing the experienced and expert teachers, I'm sure, right, Sharmila said, Vasna madam is the teacher of teachers, and all others, all other examiners, the questions were not only testing the nerves of the students sometimes, as well as testing their recollecting power and knowledge. So it was really a very informative and educative session. I'm sure this will be useful for all the exam going PGs and some of them for practical points as well. And I should thank and congratulate the examiners, Dr. Vasanta, Dr. Chandrasekhar, Dr. Murli Ariga, and it was real grilling in glaucoma session by Murli Ariga, and Dr. Chitra, Dr. Vijay Shanmugam, so in his own inimitable style. So I'm sure this is a very useful session for the presenters as well as all the postgraduates who are seeing or watching this program, not only today, but also we're going to check it in the TNOA website. So all these resources are available in TNOA website. So please go back and if you missed anything today or any other TNOA programs, you can go back to our website and check the resources available. Should congratulate the first presenter, Dr. N. Vedavalli. So thank you for presenting. So this is your certificate. It will reach you tomorrow after the signatures. And so in appreciation of Dr. Tarani Priya for your contribution as a presenter and as well as facing all the examiners with Gutso, and the first presenter, Dr. Shanmuga Priya. So thank you for all your contributions and best wishes for your exams. And thank you, Sharmila, for bringing this, convening this program and bringing all the expert examiners.
God bless you, sir.
And Vasna madam will not forget you. So we'll keep disturbing you again for the next programs, not only the PG updates, but also all the training and knowledge enhancing programs from TNOA. So thank you, Chandrasekhar sir, Dr. Vijay Shanmugam, Dr. Lata, and all others who are staying with us now. So thank you all so much.
Thank you, sir. Sir, the presenter can be used for postgraduate examination because they have to present.
Yes, sir. Yeah. So all of them.
Yeah.
Thank you very much, sir. Thanks to everyone.
Thank you so much.
Thank you.
Thank you, Nirmal and Gauri.
Thank you. Bye.
Thank you.
Thank you, Sai and Manjula, for hosting flawless.
Thank you, Sai, sir. And thanks to the sponsors.
Welcome, doctors.
Thank you, sir. Good night.
Thank you. Good night, Sharmila.
Good night. Good night.